And now our second panel is going to discuss possible reforms to Medicare and Medicaid. This is for a lot of wonks that are really into this. So I'm looking forward to them just, telling us how to solve these problems. Kelly Close is the founder and chair of the board of the diaTribe Foundation, a nonprofit dedicated to improving the lives of people living with diabetes and pre-diabetes. She's also the founder of Close Concerns, a healthcare information firm focused on diabetes and obesity. I love anyone that's involved with literacy on these subjects, and sign me up too. Dr. Marie McDonnell is the director of the diabetes program at Brigham Health, where she provides clinical, academic, and administrative leadership of the hospital-wide diabetes program. And finally, Dr. Gary Puckrein is president and CEO of the National Minority Quality Forum. Dr. Puckrein has long worked to eliminate health disparities for racial and ethnic minorities through data-driven initiatives. Dr. Puckrein, it's great to see you again. Let me start with you. We've had the conversation before. I'm always grateful as well that you take our call to join us. But as we sit here again, I sort of feel like we're at a political inflection point. So many political inflection points are also economic inflection points. They're opportunities to scramble things in new and different ways. What do you think the equities are that we have to get right on the fight against diabetes and dealing with the fact that this disease doesn't hit this country evenly? It hits very unevenly, but would love to get your insights.
Yeah, I think the moment has come where we should start talking about reimagining CMS, the Center for Medicare and Medicaid Services. It is actually fundamentally broken. It acts more like HCFA, which was the predecessor agency, because it's focused on financial risk and not patient risk. Right. So when you look at diabetes, for example, 60% of everyone with diabetes in the Medicare program goes to the hospital or the emergency room every year. An African American with diabetes and ischemic heart disease has a 90% hospitalization rate. 38% of the Medicare budget is being spent on people with an underlying condition of diabetes, and the program has not taken leadership on remedying this problem. We have to reduce diabetes-related hospitalizations. We have to reduce the risk of people going to the emergency room, getting disabled, and dying for diabetes. And Medicare and Medicaid has to lead the way, and the program right now is fundamentally broken. It's not doing it.
Well, thank you for that, and that's a big challenge, but one I think is very important. Kelly, tell us how we solve. I saw you smile when I said I'm going to give you all the power in this to fix this. What do we need to do in Medicare and Medicaid? And I got to tell you, because one of the things I really liked about the profile of what you're doing is you're also committed to literacy. I mean, if you have this, it's like a journey through a never-ending morass, a labyrinth. I mean, I feel, and maybe other viewers see it differently, but I would love to get your sense, Kelly, on how you would shift things, what you would prioritize, what do you think needs to be changed?
Oh, yeah, thank you. And I mean, what an honor to be here. And it is, diaTribe has this priority and these sets of priorities in and around literacy because of leaders like Gary, because of leaders like, Dr. McDonnell. So we are very lucky that we get to see them and that we know that, we absolutely have to start with the science and the data and the technology, and we must be able to get there. I was really happy seeing the head of the ADA, Tracy Brown, standing in the Rose Garden a few months ago, and that some work has been done on insulin for seniors. And we need to think for everyone, how can the health be there to start with, and that we're working on kidney health, on heart health. There are amazing things that have happened on the scientific front in terms of that. And we need to make sure, that just like Cynthia said, that the access and affordability, the coverage is good. And then to make sure that the affordability is there, so all of this out of pocket is not so stressful. And it is healthy foods, it is WIC, it is school lunches. It is multi-stakeholder work. We now have, I think, continuous glucose monitoring, Medicaid coverage of some sort in 37 states. We need to figure out where is it the best and use that as the model. And use that as the model for GLP-1 and for SGLT2s. These are classes of drugs that allow people to lose weight to help their glycemic control without becoming hypoglycemic. They reduce heart risk. I mean, 10 years ago, none of us would have thought about taking medicine to reduce heart risk. That is how we get back to what Dr. Garg was saying and keeping people out of the hospital and so forth. I would hand it over, to Dr. McDonnell and see what else she would like. And again, to Gary. I mean, Gary knows who needs what, and we all better watch the census data and the zip code data that he will be coming out with at National Minority Equality Forum. We need to be watching that super closely.
Thank you, Kelly. And I got to say, I'm just so impressed with you walking during this conversation. And I'm going to try and start. It's going to be my new ask, maybe for Christmas from my employers here, because it's a really inspiring thing to see you do that. Let me go to Dr. McDonnell and ask her, the same question of, what would you do on the reform front? But let me also ask you, Dr. McDonnell, are you familiar with the consensus statement of these leading diabetes groups on some of the reforms they've looked at that really deal with, honestly, they deal with pretty, I'm editorial, so I can say this, but pretty common sense stuff when it comes to, rebates, when it comes to patients getting on the front end of the dollar on making sure that, core services that have been affecting people's lives, continue as we sort of see the healthcare system evolve. And so I'm just interested both in answering, what would you do to reform Medicare and Medicaid on this front? But two, why are these principles? I always wonder when somebody puts out a bunch of principles and said, here's our consensus statement, I ask, why is gravity so hard to get there, right? So what's going on?
Right. Yeah, we have, especially in COVID, it has shone this light on the fact that we need to meet patients where they're at. And I think a lot of the principles we're trying to infuse into CMS and their new policies has to do with that. Patients are at home most of the time, and our seniors, actually, the prevalence of diabetes is rising faster in our senior population than in any other population. And they become more complex as they get older. And as we heard from Gary Puckrein, that these patients are in the emergency room way too often. So why don't we take the opportunity now to really identify that population, make it easier for us as providers to provide care in the home, or even provide consultative services in facilities where they're living if they're not at home. The point being that there are too many barriers for us to provide care for the patients where they're at. Another example is a program we have worked on for many years, trying to capture patients who do come to the ER and prevent them from a long hospital stay. Many of our patients are admitted to the hospital because at that time and moment, there's nobody there to catch the football with their diabetes and say, I know, Mr. Smith, you're having trouble, your blood sugar is very high, but if you come into this program and you can stay at home and do this, you will be okay. And you don't need to stay in the hospital and sit and watch TV and be fed French fries, which is unfortunately what the hospital looks like for many of our patients with diabetes. And Kelly knows this. So I'm going to say simply, Medicare needs to, and CMS needs to support clinicians to take care of patients using telemedicine, remote glucose monitoring, and also just help us coordinate care with the acute care services to make sure patients are not lingering in the hospital. It's one of many, and I think the cost of medications, I was just doing the math on the recent data. If you take 40 units of insulin a day, which is a pretty average dose, out of pocket on average, that's about $400 a month. And there are many patients who don't have the money for that. They don't have the insurance for that. Right. And this is why they're rationing insulin, rationing medications, and they end up in our hospitals. So I'm very passionate about keeping folks at home with their families and safe.
Well, let me ask you just another question. I want to take a question from our audience that has come in, but I want to ask you just quickly, the three of you. And again, this is just my own experience. A former journalist colleague of mine, Olga Kazan, once wrote about the Baltimore area and a superstar woman and her family, lots of diabetes, lots of other chronic conditions, looking at parts of Baltimore where there were 20 years age difference in life expectancy between one part of Baltimore and another part of Baltimore. And they're sitting right next to Johns Hopkins University. And I guess my question is, despite the various reforms we have in Medicare and Medicaid, what is the state of play with research universities, with these large health centers? And I don't mean to typify them all in the same way, but is the relationship between those great institutions and on-the-ground healthcare and going into communities where it is just a lot tougher, and you have people not going in for care because of these speed bumps, these costs. Do you think that we need to focus? I mean, there's one look to look at reform, another side to say, we've got places of excellence in the country that aren't reaching out the right way. So this is sort of a pet question of mine. Kelly, what are your thoughts?
Well, I love hearing just your focus and passion and commitment to everyone doing as well as possible, right? And I mean, hey, the research universities are doing they're doing a lot of really good work. I think as we listen to Dr. Garg, I mean, the telehealth, making sure that the reimbursement, I think this is my husband. Hi, Johnny. Sorry, guys. But really making sure that the doctors are set up to do as well as possible. I mean, Dr. McDonnell, that she went into this area, and Dr. Puckrein, they're doing labors of love, but we need to make this oncology. We need to make this many other areas that are going to bring people in. And for where the science is, there are so many better things to do. But Gary is, he can tell you, as you've heard from him before, you have to get everyone into the trials, and you have to make sure that no one is left behind. And for some people, they don't even have broadband access, I think looking at innovative ways of reaching patients and asking them. A lot of them are online and a lot of them aren't.
Right. Thank you. Gary Puckrein?
So, it's always a challenge because healthcare is a deep collaboration. There are a lot of pieces that go into healthcare. So it's hard to single out one problem, but let's give an example. We have these new CGM devices, time and range. They're helping people manage diabetes. My grandson had diabetes. I remember taking him to the beach, and I felt like someone who'd given me an automobile with no gas tank, with no gas gauge, right? So every once in a while, I had to stop and stick his fingers in and try to figure out whether he was his blood sugar level was about to collapse. CGM solves that problem, right? It helps people with diabetes manage their disease. Yet and still, it's very, very hard to get a CGM in the Medicare program. Minorities do not get a CGM in the Medicare program by the data, right? That is a health disparity right now that's going on in the Medicare program, let alone the Medicaid program, where we could control diabetes. So it's hard to look at the academic centers and say, that's a problem area. I think really, and what I'm getting at here is, we have to decide that we want to reduce patient risk throughout the healthcare system. That when somebody comes into the healthcare system, the purpose is to reduce their risk for a hospitalization, for an ER visit, for disability, for mortality, and not focus on financial risk, right? So we prioritize the system to look at financial risk, and what ends up happening is that we elevate patient risk. We put them all at risk because we don't make available the technologies that will reduce their risk across the healthcare system. And that's why they're going to the hospital, is because it's the way in which we've built our healthcare system to focus on the financial risk and not what's happening to patients.
Thank you for that. Marie McDonnell, before you jump in, I'd love you to answer my question because I know you're going to be great at it, but I also want you to ask the question that we have from our audience member in with it. So let's hear from Michelle Oshman.
Hi, my name is Michelle Oshman, Vice President for External Affairs at BIO here in Washington, D.C. I'm wondering, given the disproportionate impact that diseases like diabetes and its comorbidities, namely heart disease, have on minority communities, how do we ensure that we have the right regulatory and policy environment in place to incentivize new treatments and new cures for patients who need them?
So, Dr. McDonnell, it's two easy questions.
Yeah, right. Thanks. Well, I'm just going to say the first question you asked about the academic institution and some of the disparities we see right around those institutions, I think it's complex and probably more a reflection of what we're seeing in urban environments and social determinants of health, which are just, I think, more highlighted in populous areas around in urban areas. And we need to address them. And I'm thinking of the CMS model. To give credit to CMS, they did try in 2015 to lift up this chronic care management model where they would pay for up to 90 minutes of non-traditional face-to-face care. So not face-to-face, rather, either virtual on Zoom or on the phone. But the challenge of getting reimbursed for that, just like we see with CGM, is so high that many programs aren't adopting that strategy. But that would be a way to reach patients where they are in the community and not put the stress on them to find us once again. The second question is how to make sure that patients get the treatments they need. Is that what I'm hearing with that question?
It's basically, what Michelle Oshman is asking is how can we get the regulatory and policy environment shaped in a way that there's an incentive for new treatments and new cures, So part of the question is not just, what we were doing in the past. Part of it is, and this is always the tension, right? The tension is innovation, new treatments, new risks moving forward, but also keeping it affordable and high access. And so I'd love your insights. She would love your insights on that.
Right. I'm going to just say that we need to we have innovations that have not been put into play with our patients. We need to actually look at why that's happening. I think this is the moment, and Kelly's shaking her head. How do we make sure that the very now standard practice of CGM is in the hands of every single patient with type 1 diabetes, and you could argue every single patient on insulin? It costs the same to use 4 finger sticks a day, these painful finger sticks, than it does to use the newest, one of the newer, simpler CGM devices. It's the same cost as from what I can see. So why are we not doing that? How do we change the regulatory environment? I think that there has to be some more listening to the clinicians and having us sitting at the table, more people who are actually taking care of patients sitting at the table. And then listening to Kelly, who advocates for patients themselves. And Gary bringing in the social determinants of health and making sure everybody understands that there are barriers between patients and technology and medicines that we don't understand. We don't understand necessarily why these biases exist or how to get rid of them. But we need to know that they're there. So break them down, make it easier. One less phone call or email or fax would be a blessing for all of our patients just to get what they need.
Well, thank you. I wish we had more time. We'll give you 10 seconds each, Gary and Kelly. Go ahead, Kelly. Yeah.
Also using Medicare, not just to have CGM for people on the most intensive insulin, but anything that is causing hypoglycemia. Sulfonylureas, this is the next step.
Well, that's great. Gary, 10 seconds for you, my friend.
My word is focus on reducing patient risk. Activate people like Kelly and Dr. McDonnell, allow them to focus on reducing patient risk. I think we'll have outcomes that we'll all appreciate.
Well, I want to thank you. I really appreciate this conversation, and I feel better that we had it, and I hope we can do it again. Dr. Gary Puckrein, CEO of the National Minority Quality Forum, Dr. Marie McDonnell, the Director of the Brigham Diabetes Program, and Kelly Close, founder of the diaTribe Foundation. Thank you all so much for joining us today.
Thank you.
Thank you so much.